So today's chronic disease support session is part 2 of what the eye tells you about your health. And Dr. Carter did a brilliant job presenting to a whole bunch of doctors and lay people about, glaucoma is Alzheimer's of the eye, and Alzheimer's is glaucoma of the brain, and how cataracts is a sick eye and a sick body, and it's a predictor of actual mortality from cardiovascular disease. So we're just going to do a very, very short review, like 2 or 3 slides, and then break right into the new topic and try to finish up on the eye stuff today. So it's crickets out there in terms of this as a diagnostic tool, and in terms of looking at the eye as a screening tool, because in the standard world, you're either healthy or you're sick. So seeing an eye pathology and relating it to future cardiovascular disease, that goes against the model, I guess. But this is an NIH study, ARIDS, Age-Related Eye Disease Study. And, they sell ARID vitamins, but they don't really do much because a little B vitamin is good for you, but it doesn't knock out the profound inflammation associated systemically with these conditions, especially when you're just putting it in the eye. And then, there's high mortality associated with just cataract. It's part of your immune response. So we talked about that last time. And then here's the mortality curve. And you don't die from cataract surgery. What this simply means is, here's the continuum. Sudden visual change. The early nuclear opacity, the beginning of a cataract. And now the cataract's so bad you have to have surgery, otherwise you have really poor vision because of the central visual field being blocked by this opaque protein formation that's actually part of your immune system. So you see a nice progression, 36, 40, 55%. As the cataract gets worse, your likelihood of surviving goes down. So there's something systemic going on. And that's an ugly slide. And then I finally got it right. 17 worldwide studies. Some of them didn't quite get it. They thought it had to do with surgery and the stress of the surgery, but it's clearly high correlation in most of these studies to early mortality and cataract. Yet it's still the #1 surgery in the world. Very effective. I would never discourage anybody from getting cataract surgery unless they want to go the total functional route. And Dr. Carter last week mentioned L-carnitine.
L-carnitine.
L-carnitine as something that seems to be working against the misfolded protein. Now we have to figure out, and I'm sure Dr. Carter knows, whether it's treating the infection or just dissolving the protein formation. But this is an antimicrobial peptide showed by Harvard, so you want that in your body. You want that. Amyloidosis is a very prolific disease that no one's talking about, and it's basically the amyloid building up in various tissues. We see it in the eye, but people might have it in their joints, in their brain, obviously Alzheimer's, and other parts of the body. Amyloidosis is simply an innate immune response to some inflammatory or subacute infectious process going on either systemically or focally, locally, in that tissue. That's the take-home thing. And it doesn't mean you're going to die young. Okay, Carrie Gelb, the optometrist from All Docs OD, the leader of that group, did that documentary, and I put it on my blog some time ago. It was supposed to go out in March at a big eye conference, but COVID kind of disrupted that. But he was doing testing in Costa Rica of people over 100 years old with cataract. Why aren't they dead? Because that's the tertiary immune system working for them. So that late in life, they've done very, very well fighting all the insults that could take them down. And I told you last time that the 102-year-old male, 103-year-old male challenged Carrie to a wood splitting contest, and he knew how to wield an axe, and Carrie didn't. Carrie fancied himself being a Yankee, and I looked at him swinging that axe. I said, "Carrie, dang good thing you're an optometrist." So here we go on with the show, but this is we're going to now transition from really the front of the eye, where cataract is, to the back of the eye, the retina, in more detail. We did talk about the retina a little bit. But this paper came out in 2003. And Lee Goldstein and in particular, and Rudy Tanzi, the chaired professor of neurology at Harvard. Where's Rudy on this paper? There he is there. We're on the morning show circuit talking about, how the eye could be used to detect Alzheimer's disease. That was 2003, 2004. They did the research in 2000. And nothing's really happened. I mean, maybe optometrists have heard about it, but they won't admit it because they're not MDs. But what they showed, and at the end of my Alzheimer's book, or in chapter 11, I think, or no, chapter 6, I break down this paper from the scientific to the layperson in terms of what it all meant. But even when they looked at the fluid in autopsy patients in the brain, the cerebral spinal fluid, or what's the fluid in the brain called, Michael?
CSF.
Yeah, and then in the optic chamber, and when they took those two fluids and compared that using all the advanced techniques of Harvard, they showed the precursor protein to the amyloid, the cataract, to be essentially the same in terms of concentration depending on how progressed the disease was. So the eye is an extraordinarily good biomarker, but not always. One must realize that with focal infection, you can have infection just in the eye and not in the brain, and vice versa. So in those instances, the eye won't be a canary. So it's not 100%, but it's a heck of a lot better than what we have today in terms of screening people early for neurodegeneration. So what they call it is a systolic beta amyloid deposition. It's the 1-42 amyloid, also known as a supranuclear or cortical. Your eye doctor will know it as a cortical cataract. That is the Alzheimer's cataract. And once again, they don't look at it particularly because it very seldom impacts vision. And their job is to support vision, not worry about systemic diseases, unfortunately. So if we dive down deeper, this is directly from the Harvard study that I just showed you, and this is where it shows up. This is where a nuclear cataract will show up, and both these people had nuclear cataracts, but they also had the cortical cataract. And so the challenge is I can't QC the quality of the optometrist, but that's why I have the sheet, and I want to know what they see from a cortical cataract perspective. And normally it requires more thorough dilation to open up the pupil, to really look back in the corner of the lens, and then more light intensity than they normally use to look at a nuclear cataract because they're harder to see. So, they've got to do that. It's very hard for me to reach out to them and say, this is how you do this, but they should be trained on it. My son, by the way, just started his very first day as an optometrist today, and he understands cortical cataracts. So this is really, really interesting. This is an autopsy brain. I can't remember who did the study, but, pathologists will take the brain out of a dead person, they're doing the autopsy with, and with a knife make slices and stain and look for the plaques, if you will. And so that's what a plaque fibril looks like in an autopsy Alzheimer's brain. And this is a picture from Dr. Tremp's clinical office, one of his patients that had almost stunningly the exact same looking fibril or cataract, early cataract formation in the lens of the eye. And of course, this person had some level of either glaucoma or dementia going on. But this is basically why we say that the eye, it's a living biopsy. This is a biopsy, tissue biopsy of the dead, and this is a living biopsy, just using light to see expose the unfolded protein that's just refracting the light from its normal path. And even though this would be controversial for most ophthalmologists and optometrists, like Dr. Carter and I experienced with the NIH people today, sometimes they just don't get it and we have to hit them with a sledgehammer. But the cataract just doesn't form out of the blue, okay? It's a progression. Guess what? It's on a continuum. Son of a gun. So the earliest thing is a research tool called collaboration. And what happens here, I'm getting a little technical, but what the heck, but it's easy to understand. If I have a big pool of water and I take one little drop of oil and put it on top, and you see that oil spread, and you can actually see the rainbow colors now on the top of the water from that oil spreading out. That's what a really skilled person in optometry, research optometry or ophthalmology can see with a device, and they see basically just little areas of swollenness. And it doesn't mean it's irreversible. This is very, very early on. That's called coma aberration. So it's the earliest sign of a lens change. It doesn't mean a cataract. But most likely, if it progresses, will progress into a cataract. The next thing is called pseudo exfoliation, which looks like little teeny particles, like you're looking up in the sky in Montana where it's very dark and you see the Milky Way. That's what you see. Then you see what's called the cortical fibril. Then you start seeing the cortical spokes, and then it can emerge into a cortical cataract. Very few people make it to this level. They die first, But so there is a progression. Your optometrist will not be checking for coma aberration, never. They may understand pseudoexfoliation, but I'm not asking about that. I'm just really looking at the cortical fibril. And the reason why I'm not is because OCT, looking at the retinal nerve fibrillae in the back, which we'll talk about, will really distinguish, if these processes are leading to neurodegeneration. So that's what we're really focusing on. And when you see it in OCT, it can be very, very early. I had this 42-year-old with migraines. It's all she had. She was an executive to the CEO of the company I was working with. And she had migraines. She was taking 4 medications every day for 18 years. And when we ran OCT, she had just the slightest neurodegeneration. So see, migraine is an energy crisis that's leading to death of the neurons or the retinal ganglion cells. So that shows up. But 42 years old, 18 to 40, very resilient, doing a lot of repair and recovery. So it's not developing very quickly, if you will. Let's see what else we have. So now I'm going to transition to age-related macular degeneration for a moment, away from the cortical cataracts. And what we're seeing here is a little orange globule. It's called drusen, drusen, drusen. And I would have that, if you're going to go for an eye test in terms of looking at things systemically, you want to have that little word in your vocabulary. And of course, they'll say, well, there's small little drusens, like they're little LDL particles, and there are big drusens, and they're different. In my world, they're both misfolded proteins or unfolded protein response, so they're not different. But drusen, it's called a fundus camera. It's on my list of tests. Slit lamp for looking at cataract in the front. Fundus camera for looking at sort of the broad view of the retina, and then OCT for looking at the very tiniest aspect of the nerves. But drusen is something no one wants to have, and clinically it's called dry AMD. And in the standard of care, dry AMD is simply observed. Kind of like everything else in medicine. We don't do anything until it gets extreme. So, but a lot of people don't progress to the wet version, which I'll talk about in a moment. But there may be reasons for that. 1, it may rectify. 2, it may be stable. 3, the patient may have died because there's a high mortality rate associated with age-related macular disease. So how you know for sure? Our blood panel, or a decent blood panel. Doesn't have to be ours, but knowing how to look at it from a microscopic view, not from a sledgehammer view. So we see the drusen here, and then we see these little red spots. That's bleeding. That's bleeding in the back of the eye. It's no different but that's spontaneous bleeding. It's like if your gums were spontaneously bleeding. That's not good. And if your gums bleed and your eye's bleeding, where the heck else is it bleeding? I mean, you're a hemorrhagic stroke candidate extraordinaire under those circumstances. And you can see that when you just have a drusen, mortality goes up, but not much. So dry AMD doesn't show a huge increase in mortality, and this is probability of death on this curve versus years. But when it's bleeding, what that really is an atherosclerotic vulnerable plaque that has burst. You know, and the holy grail in cardiovascular disease is identifying vulnerable plaques. Well, you know, when blood is exuding from a tissue, that's a vulnerable plaque. Very telling. So here's kind of the picture of it. Here's drusen, the little drusen. That's just the, don't be confused about this. This is the optic disc. That's not the drusen. But out here in the field of the retina, you see the drusen. And then this, the choroid, is the most vascular tissue in the entire body. As I explained last time, you know, the eye, you know, you sleep for your eyes and your brain. Same thing. Because, you know, the light's hitting the eye, the photon, and you're converting it to an electron. It's a lot of work. That's why you get eye fatigue. You know, it's not just focusing, but it's all the work that the eye's doing on a moment-by-moment basis. It's never taking a break. So that's why there's such a high, you know, it's not a lot of blood flow, but on a cellular basis, the concentration, the amount of blood flow is extraordinary, more than the brain. The brain is 10 times more than the rest of the body, and the retina is more than the brain in terms of blood flow. So, and this looks a little bit like that zit I talked about last time. We're starting to get a little accumulation of cytokines, of the immune system, trying to capture and eradicate an inflammatory process. And then ultimately, that plaque can get worse and worse and worse, and it will rupture, and that's when you get bleeding. So the bleeding is signs of a vulnerable plaque that actually ruptured. Now, I think, if we're lucky, I don't know what the next slide is, but I'm going to prove to you, every one of you, that you know more than any cardiovascular specialist. Okay, so let me test that hypothesis. When you're home and you know there's a clogged drain, which drain is more likely to clog first? A little teeny drain or a big wide drain? Anybody?
Small one. Small.
Like when you have the filter, the little sieve, the little screen, that, you know, that basically makes that drain smaller and it clogs easier and backs up, and then you take the debris out of it and it drains like crazy. Well, in cardiovascular disease, this is something Dr. Tremp taught me, and you know, he was right one time, Michael, when he said, well, I keep telling him the same thing, and he's finally starting to get it. But the disease of cardiovascular disease is a disease of the small vessel of the large vessel. Okay, and let me explain that a little more clearly. Every cell in your body has to be within 3 cell diameters. I don't have a third hand. Nikki, my little doggy, no, she's not going to contribute. 3 cell diameters of a capillary. And that means in a large vessel, like the carotid artery, there's all kinds of vasculature, small vessels and capillaries surrounding that. And it's in the small vessel where the disease emanates. So in this case, all these small vessels. So in your heart, the big vessel didn't give in. Well, it did. But the small vessels around it, supporting it, were really what was diseased, leading to that plaque. That's why Alzheimer's is a vascular disease. It's the small. It's always small vessel disease first. Okay, and then infiltrating the larger vessels. Okay, when I say always, my wife Jasmine, she always says, "Don't say always." So everybody has to know that I'm a Gaussianist. It's a bell curve. So every time I say always, think about a bell curve. So, but for the most part, it's a small vessel disease. Somewhere I have a picture of that. That'll be another presentation we do on cardiovascular disease. So the reason why drusen, I'm skipping around a little bit, but I'm back to the, let's make sure my brain is working right. There's the drusen, good. Here's the drusen again. And this is Dr. Anderson out at UC Santa Barbara, and he's been publishing on this. Not a bad place to be doing medicine, right, Santa Barbara? East Tennessee is pretty good too, but he's done research on drusen now for 25 years, and I happened to have a conversation with him a while ago and just thanked him for his work. But what he showed is not only is it the amyloid protein of Alzheimer's in the cortical cataract, but it's also in the drusen. And this is his landmark paper that says the Alzheimer's A beta peptide. You'll see this beta amyloid, 142 beta amyloid, A beta peptide. It's all the same thing. Is deposited at sites of complement activation. That's just the immune system. And pathological deposits associated with aging and age-related macular degeneration. They have to make a fancy title because it's going into a medical journal. But then basically he's saying drusen is also the amyloid plaque protein. That's the translation. Okay, so you can see the connectivity. It's all coming together. Now I guess we're going on to the retinal nerve fiber layer. And this was actually when my son graduated from optometry school, a thesis under the direction of Dr. Tremp, which was retinal nerve fiber layer thickness in glaucoma is related to Alzheimer's disease. So, you know, when we see a change in the retinal nerve fiber layer, a very exacting test, it could very well be a sign of what's going on in the brain. So what's really cool about this device, if you haven't had it, every eye test is the same. You take your glasses off, you put your chin on some holder, you look into the back of the device, try to stay fixated and focus on the back of the instrument where you see the little dot of laser light, and they just take pictures. And this is what it should look like. So I've had many tests come back where there's something broken here, or there's a discontinuity in the two layers. Don't accept that. I mean, I know it's hard for you to tell you that and tell your optometrist, but I've seen many, many lazy technicians come back with a retinal nerve fiber layer slice like this. That's not usable diagnostically because they did a botch-up job, but it should look somewhat like this. It can have bubbles in it if you have, you know, a retinal detachment or other types of pathologies, but it should look clean from the left to the right side. But what's amazing about this technology is we're looking at this little teeny slice of nerve where the sunlight is, or the light is hitting on it, and it's being converted to an electron. And we can measure, you know, XY or XZ plane thickness, but we can also measure three-dimensional volume. And so we can measure, just like they measure an MRI, they measure really volume of your brain and the change thereof. We can measure thickness and volume and of the neurological tissue. And there's some indication that different facets of this layer are related to different types of neurological diseases. We just generally look at, are we seeing atrophy in general? Because from our thesis, it could be focal infection somewhere in the brain, but the process is largely the same. This is where QEEG, which maybe Dr. Carter or maybe Dr. Berman will do a seminar on that, where that technique really looks at brain waves and can do much more accurate mapping of where the dysbiosis is, or the dyshomeostasis is in the brain. So it's a very interesting test to complement the OCT, but it's really looking right at the brain instead. But it wouldn't be as precise at measuring the early onset of neurodegeneration. Anybody have any questions so far? Because I mean, I know it's somewhat complex stuff, but the translation of it is actually very simple. Okay, I'll dart on. So it's really complicated to read an OCT output. This one here, pretty good. This one here, pretty bad. It's as simple as that. All this sophistication boils down to a thickness and volume map that then is titrated into standards. And what I mean by standards in this case is thousands, tens of thousands, hundreds of thousands, or even millions of scans are recorded in a database. And based on your age, they map out normal versus abnormal thickness and volume with this simple color scheme. And so I expect to be paid richly in the future if you do an eye test for telling you that green is good, yellow is not so good, and red is bad. It really is quite that simple. And this is what it looks like. I mean, that basically the green bars, yellow bars, and orange areas, rather, are normal for that person based on the statistical cohort for that age. And then the black line is where that particular person fell. And in this case, it's the same person, different eye. We can see the disease manifest in one eye before it manifests in the other. That's really the focal aspect and the spreading of focal disease. And Dr. Tremp would always say, this is the power of the eye. You have one brain, but you have two eyes. So, you can have the good eye and track how we're doing on the bad eye and see how therapy is working. Oops. I'm as bad as the slide projector lady we had for BARDA, who was like three steps behind the speaker. It was a nightmare. But so this is just a paper that shows the retinal nerve fiber layer thickness for healthy and diseased people. And Berisha is actually Dr. Tremp, his work. And you can see that, someone with glaucoma may have even worse retinal nerve fiber layer thickness than someone with dementia. But the dementia persons will generally have much lower retinal nerve fiber layer thickness. And once again, where they wind up on this continuum is really a measure of how much the neurodegeneration is overlapping between the eye and the brain. That's why this glaucoma sufferer may have dementia as well, but we're seeing really profound reduction in nerve fiber layer thickness, whereas the Alzheimer's people may have less of a glaucoma component in their disease. So what I want to point out here, and Dr. Tremp and I wrote this paper about, the continuum of Alzheimer's and how we really need to be looking at the progression towards Alzheimer's from pre-birth to death, okay? And so this just shows you that OCT is not just about diagnosing glaucoma or neurodegeneration, but it's all a continuum in the brain. So optical coherence tomography findings in patients with bipolar disorder. One of Dr. Tremp's favorite things to do, a 19-year-old would come to the office from some wealthy person on Nantucket, because he was in Boston. And Nantucket is loaded with ticks and Lyme disease. And he'd look at the OCT and he'd go to her with his French-Canadian accent, so tell me when the wheels fell off the wagon, in his accent. And they're all like, what are you talking about? He said, I'm looking at your eye and I can tell through my translation to the brain that you probably have some emotional issues going on. And, some people just, they get out of, they drop out of society literally because their brain is so inflamed at a young age. And, he was very frequently right. Lyme disease will do this. Kerry Gelb, I mentioned, I don't want to get into too much detail, but a relative of his child dropped out of college, bright kid, and was just staying at home and basically became an introvert. And when he met me, I said, look for Lyme, and they went down and got treated by Dr. Singleton, LymeDoctor.com in the Baltimore area, and the kid returned to school. So, obviously in the young, neurodegeneration is not very easily reversed, but it's more easily reversed than someone who's 82. But, profound effects. We had an extraordinarily wealthy guy founded Circuit City. Founded CarMax. He was the CEO of Circuit City, and I think I told the story. He came up to Dr. Trump. It was a zoo. Everybody wanted to get tested. They flew up in their private jet, but they wouldn't follow the protocol. The wife wasn't on board. But years later, one of the daughters called me up and said, my husband wants to kill himself. And I said, go see Dr. Singleton, because they're nearby, Richmond to Baltimore. And 6 months later, Dr. Singleton called me up and said, he has his brain back. So, regeneration is possible. All these things I'm talking about here are long-term antibiotic treatments. And Dr. Singleton is a member of the IFM, functional medicine and all that, but sometimes you got to pull out the weapons. And particularly in younger people where they're resilient to it. Older people, we got to be careful. I mean, if anybody is working with me that has someone older that has, neurodegeneration, there's a high seizure risk, there's a lot of complications in creating that die-off reaction from the infection in the brain. That's why I go very, very slowly and cautiously. But the disease, all these diseases overlap in terms of neurodegeneration. You have inflammation in your brain. That's why it's not working well. The wiring is messed up. Research in bipolar disorders suggests structural brain abnormalities. No kidding. They have amyloidosis going on. They have the amyloid plaque starting to form. With autopsies on 20-year-olds, they already have amyloids, and they may not have any conditions. Amyloid's tricky. A lot of things can cause it, trigger it. So there are 90-year-olds with amyloid with no memory problems, and there are 90-year-olds without amyloid that do have memory problems. Different mechanism. Maybe it's more focal. They're not looking broadly enough at things. So, it's no fool's game to understand when you're looking at pathology, but usually the blood tells the story. You have symptoms, you have a poor CNS vital signs test, you have infection. It's usually the same kind of players every time, even when the pathology is not clear. It's hard to do pathology on the brain. That's why we use the eye. It's not perfect, but it's a heck of a lot better than having your skull opened up. Anybody did it for that? Usually I go too far, and I just did it again. My wife would say, too far. Optical coherence tomography shows inflammation and degeneration in major depressive disorders. And the amount of loss in retinal nerve fiber layer thickness correlates with disease severity. What Dr. Trump and I wrote is that people with Alzheimer's, they have depression, but more common is that people who get Alzheimer's had a long history of depression. Okay. So wake up, have your gratitude moment, be thankful.
Yeah, right.
Previous research has consistently detected inflammation in the etiology of depression. There's a thing called intermittent explosive disorder, and Harvard coined that term, I think, and it's people who suddenly go berserk and violent. And I talked about this a long time ago in presentations, and they have elevated C-reactive protein. So it's when we just presented to BARDA, this National Institute of Health group, it said, look, COVID-19, chronic diseases, they all have inflammatory markers. And they go, show us the proof. It's like, I think we'll move on. I did give them a piece of my mind before we moved on, though.
Good for you.
Well, it's saying,
I was mad.
only testing antibodies and PCR. I said, like, what does that tell you? What about risk? Not in our grant schema right now.
Oh, I just hate politics.
So, I have to tell you a little story about Dr. Trump. So, no one read more scientific and medical literature than him. He even read it in multi-languages. And this is Killen McCulley, still alive, 85 years old, still publishing, still with, he was thrown out of Harvard in 1969 because of his homocysteine beliefs, and then famously brought back in 1998, but he was blacklisted, he couldn't get a job. He had to commute to Providence from Boston to get a job. So one day I walk into his office, Dr. Trump's office, I'm looking at him, and he has this paper on his desk, and his 4 highlight colors, 4 colors, and 13 pages, almost the entire thing is highlighted. I said, Clem, that's a good paper, I guess, right? And he says, that's McCulley. And I said, who's McCulley? And I look him up, and he's a neighbor. So I called up McCulley, and we've become famous friends now, and he always helps me out. Great guy. But this is the paper where he explained that, this is vascular disease. The vulnerable plaques, the plaques that burst and kill you or damage you severely, are formed by obstruction of the vasa vasorum. What the heck is that? The vasa vasorum are the little teeny vessels that support the big vessels. And so it was McCulley's work that showed us the way. Trump already knew that, obviously, because he was just so far ahead of everybody else. But this paper shows, and why LDL shows up. LDL is actually involved with, the immune response, and so it's showing up at the area. And he thinks LDL is actually capturing some of the gunk, because LDL is a transport vehicle, some of the gunk that's dumped out by the immune response to the disease process. So great paper. And, of course, he's saying they're complexing with microbial remnants. So it's our entire thesis. It's like the small vessels of disease in Alzheimer's and other diseases, and that LDL goes up, not because it's bad, because it's sequestering infection, the microbial remnants. Great paper. So where are we? So let me just see how much more we have. Ugh, what happened? Talking too much. But, what I want to do, we'll just probably end on this and then take questions, is that getting the eye test, if you deem you're interested in finding that out, and I don't go against it. I think the blood's more important. But there are going to be times when the blood is not that revealing because the level of insult is so small. And then when we look at white blood cells, white blood cell production can be suppressed by viruses and peaked by bacterial infections. So, you can have a normal white blood cell count, but actually abnormal differential underneath it, like the neutrophils, the lymphocytes. That's why we do the differential and look at them carefully. So we usually can elucidate it. But, it's not always. There can be confounding factors. For the slit lamp microscope, every eye doctor does that. We want to look for nuclear cataract, or we want to look for cortical cataract, and then posterior capsular cataract as well. The Fundus camera is looking for drusen, that's another amyloid, and optic disc health. And then the OCT is looking at thickness and volume of the nerve fiber layer. And then the advanced OCTs now can actually see microaneurysms of the smallest of the small blood vessels. You literally can see the little capillary being broken off at the end rather than being contiguous. So not every eye doctor has the OCT. I think the instrument is. So that's what I want everybody to get if you're going to get an eye test. And then, Vision Source. There's around 35,000 optometrists, but 3,300 Vision Source doctors, and you can go to visionsource.com and put in a zip code. High likelihood that they will have the upscale equipment, not always, but high likelihood. And what else we have? I'll go into this. We'll get over this. It's all information, but why the eye? And Dr. Trump knew Strauline very well. He was at Harvard as well. But he said that the reason why the eye and glaucoma show up 10 to 15 years earlier, while you can see it because the eye is transparent, but it truly starts manifesting earlier, according to his work, is because the eye has what's called ocular immune privilege. And what that really means is that the eye physiology curtails inflammation, because every time you had a little inflammation, you get blurry vision because you get swelling in the retina, and probably affect the concentration or the focus of the light to the back of the eye. So it has, so the most important is privileged sites and tissue create a local microenvironment that is profoundly immunosuppressive. So that might explain why, we're seeing the eye diseases early, other than the fact that it's just a transparent set of tissue. What else do we have? So, just more information, kind of rationalizing our testing. New York Times, Well blog, inflammation at midlife tied to brain shrinkage later in life, just an inflammatory process. And really,
I'm going to have no brain left at all. I have so much inflammation.
You can rebuild, Amy, but the reason why the brain is shrinking is because it's affecting the microvessels. So you're losing networks of neurons because the microvessels, the microaneurysms, are breaking the continuity of the microvasculature, the capillaries. So the tissue, the neurological tissue downstream, depending on that microvessel, are dying. Okay. Look, a stroke, people regain some function. Okay. So these little things in Alzheimer's are like little teeny weeny mini strokes. Everybody that goes for an MRI that already has cognitive impairment has microinfarcts. These are submicro infarcts that I'm talking about that occur early on. That's why the OCT is such an important test, because it is responding. It can detect what's going on in the submicro infarct environment. Let's see what else we have. Here's just a couple papers that validate our thesis. Okay, so this was published in the New England Journal of Medicine. We now know it's a rag journal because of the stuff about hydroxychloroquine, but it's still regarded as the top medical journal in the world by a long shot. But the title is Proteotoxicity and Cardiac Dysfunction, Alzheimer's Disease of the Heart, ? Proteotoxicity simply means the buildup of a plaque, an amyloid plaque. So you can see what's going on in the eye, what's going on in the brain, and what's going on in the heart. In heart disease is the same thing. It's an amyloid formation. It's an antimicrobial peptide, as shown by Tansey and company, particularly Robert Moyer, who unfortunately I mentioned last time died of a glioblastoma, I believe, about 6 months ago. He really did all the work on the antimicrobial peptide. And A-beta, so the amyloid pathology, affects the hearts of patients with Alzheimer's disease. Well, I can guarantee you there's a high percentage of Alzheimer's sufferers that also have irregular heartbeats. Okay? And that is tied to the fact that the infection is affecting the vasculature, which is affecting the nerve transmission between the upper and lower chamber. I happen to know that could have happened to me with Lyme disease, and that's affecting the way that the communication between the two chambers, so you get an irregular heart rate. See, it's all connected. All connected. What else do we have? Oh, shameless promotion of our platform. Shameless. Let's see if I conclude with anything. Well, I think that was a good one to end on, because these are really well done studies that basically show that at the end of the day, almost everything in disease is just an energy crisis tied to a lack of blood flow through any number of processes. Sure, it can be gut dysbiosis where you're not getting good absorption, so you're not getting nutrients. You're not getting good repair and recovery, or it can be blood flow from infectious or inflammatory processes that are leading to just poor blood flow into tissue. Calcification. Calcification can occur from calcium dysbiosis by not having by taking, it's very well published that women who take calcium supplements for bone health have much higher cardiovascular mortality because they're just told to take calcium, not the cofactors that dump the calcium into the bone, not into the soft tissue. But infection sequesters calcium. One of the reasons why my favorite drug, Michael, turn off your volume, minocycline. Minocycline chelates calcium. It also kills the infection that's sequestering calcium. That's, is the perfect antibiotic? Absolutely not. There's no perfect antibiotic, and it doesn't even treat, well some of these organisms that have become refractory. But it has multifactorial activities. Lithium, we put that in our patent. Lithium has many properties associated with minocycline in terms of anti-inflammation and be able to cross the blood-brain barrier. So, there's a lot of things in our Rolodex that we like to roll out on an intelligent scale. But that's all. Next week, Dr. Carter will talk about his journey with eye and get into some details on some of the testing he did, what the outcomes were, what he'd recommend for testing, what he'd recommend for treatment, and just more on the functional aspect of what eye diseases mean from a systemic perspective. So, any questions at this point?
Is he going to be discussing his personal venture or some of his patients?
No, my personal journey.
Okay.
Mm-hmm.
Great.
Yeah. When Dr. Carter gets into talking about medicine, watch out. I'm sure it's going to be a very, very interesting discussion. Yeah.
So before our going to our own eye doctors for, let's say, our regular checkup, it would be a good idea to get from you the checkup list, in a sense, to share with that doctor.
What I have, for what it's worth, I think it's reasonably good, but I just want to make sure I don't go into great detail because I don't want to insult them. Whoops. I wonder if it's case sensitive. Have I been hacked? What I have here, healthrevivalpartners.com/I,
Okay.
is just a PDF thing. And what I want them to do, once again, most of them are insulted that you'd bring this because they're the doctor. But, I want them to kind of grade you. There are universal grading scores in optometry, and no one ever gets it. So, and I don't give them that in that kind of detail, but I just want them to, I said, give me a grade. Nobody does that, but there's standardized grading scales in optometry. So I want the nuclear cataract, the posterior subcapsular cataract, and the cortical supranuclear cataract. So if they're going to put it down, hopefully they tested for it. Give them the sheet first so they can't say, just check that one off. And then dry eye. And then, drusen and ocular hypertension. Is glaucoma noted? Optic disc variables. That's what I want them to do from the Fundus camera. I don't want them to just say, your optic disc looks good. There's much more information from a Fundus camera review. And then I give an example. It confused me because they sent it back to me. I said, wow, that's a bad patient. But that's what I give as an example. I want to see the retinal nerve fiber layer quadrants and clock hours in terms of thickness and volume. So, and then any observations and notes, and then somewhere I there I have my fax number. It's horrible that we still live in a archaic system that sends fax, because when they send me this fax, they usually send it at like 60 DPI black and white. So I really can't do much with it. But if you tell them to email me the digital, or yourself, the digital images, then you can have high resolution images where we actually can see what this is all about. So this is what I want at a minimum, to get. There are fascinating eye devices. One of my favorite ones is, it's been so long now, but you literally look into the instrument and a laser follows your pupil movement. Such a simple test. And then you just look and you're asked to fixate on a little dot at the back of the instrument. And how you can concentrate and fixate is very much tied to brain inflammation, cognition, and things like that. So imagine a target shooter shooting at a target and they hit right in the middle every time. Kind of like some lady with whose initials S.A. who did the CNS vital signs who scored like way above me, brilliantly. So like really honed right in, okay? So they give you a scatter plot from this device. Most optometrists won't have it, but if you want to look at early deterioration and inability to concentrate, there's nothing better than tracking. You have 6 muscles on each pupil, and your brain has to really coordinate hard. That's why you get eye fatigue, to hold the pupil and concentrate. So you can actually measure. They do like 100 measurements, and they plot it out like you were, target shooting. And
Is that the visual field?
no, visual field is more, the Goldman is seeing, the other thing is your vision starts contracting with these diseases, and I think Dr. Carter will be able to best answer that next week. But that's a different thing where peripheral vision, but this is really just the ability to stay focused on a single point. And obviously, if you're having memory lapses, those commands are hard to follow, and it can be very subtle to very gross. Look, someone with dementia can't follow that instruction at all. They can't even get that scatter diagram thing. They just can't really do it. So it's really measuring the early changes in your ability to control your mind, to control motor skills, motor activity. Really cool test. I swear that the NFL combines, they need to stop testing muscle twitch and start testing, what's going on with the eye, visual fields, fixation, electrical current from the front to the back of the brain, how fast your eye is reducing a photon for an electron. Just amazing, amazing technology that's largely not used out there. Great question. I think it's really important to make sure your eye doctor is educated. Anything else? Anybody else have any questions?
I have a question. You had said something about dry eye. Is that anything like dry eye syndrome?
Michael?
With what like dry eye syndrome?
It mentioned dry eye and wet something.
Oh no,
earlier.
dry macular degeneration and wet. No, totally different. Yeah.
Oh, okay.
But dry eye is an inflammatory condition and may be a precursor to what's going to lead to. It may be on the glaucoma continuum, because if you're having problems with the drainage and things like that, it may lead to increased pressure. Not an expert on that. That's why I had Dr. Trump and other eye doc specialists. Michael, did I go in the wrong direction with that?
No, it's kind of like that, but it has to do with the tear ducts and the meibomian glands and all of that. But yeah.
The reason I asked that is because when I came back from Desert Storm, I was diagnosed with dry eye syndrome.
I got you.
And I've been doing drops ever since then.
What drops do they have?
1991.
What drops do they have you on?
It's just a natural tears type drops.
That's what I do. I have dry eyes as well. So that's, from an internal perspective, the essential fatty acids are most helpful, doing like high level oil and
I take it, Dr. Tom got me on.
Dang tootin'. Yeah, but it's a lifelong pursuit, Alan. I would, it would be tricky, but I think you know, like I said, I think last time, you know, I got to attend some discussions with the chief medical officer at Canyon Ranch. And, you know, doctors quietly behind the scenes do things a little differently than they do for lay people. So they will prophylactically treat themselves periodically for the parasites, for virus, for things like that. That's why I'm offering some of these things that might sound a little crazy. But, you know, it's hard to get it done, and Dr. Artemanoff will work with us. But I think, you know, everybody should look at ivermectin as a treatment, just to do it prophylactically, no matter where your state of health is. Do a parasite purge every, you know, 2 to 5 years. Do a virus purge every 2 to 5 years. Because these things, they don't just, they sneak up like this. You know, that's why it's, you know, it's so insidious. So, you know, doing something like biocidin, Alan, is an herbal antibiotic. You can do, you know, a 2-month treatment of that every year, just to sort of get your immune system supported a little bit against some of these buggers that might be more clever than just the nutrients in the food that you're getting will handle. We want everybody to fall off the cliff, you know, when they're, you know, 80 plus, 90 plus. We don't want people to have disease. And, you know, explaining it to BARDA, NIH today that, you know, we're on a continuum, and the reason why people with cardiovascular disease die of COVID, and the reason why people that have no symptoms die of cardiovascular disease, is because we're all on a continuum. And so our goal is just to push ourselves back down the continuum as much as we can all the time. I mean, look, we want to go out there and live life and be exposed to things, you know, and I think, you know, the lady on the Black Health Trust last night, the first presenter, Michael got dropped off. Michael, I'm still bloviating.
Oh, yeah, sorry about that. My computer just shut off. I was on my laptop and it just rebooted. So
No problem. You're still on, but I was just telling about the lady on Black Health Trust yesterday, who was actually an attorney. There were 3 presenters, Dr. Carter, and this researcher, and then this attorney talking about building gardens. I mean, why gardens are so important is turning the earth. You're getting exposed to organisms that are nascent, natural to our body. You know, you live in a bubble, you're not going to be healthy. You've got to get outside that bubble. Well proven in animal studies. They put these animals in the Cynthia Kenyon. I remember James Seberg, MD, PhD, said, "I want to have her baby." It's like, James, too much, you know? But he thinks she's a genius because she can extend the life of the worm in a closed environment. But you bring that worm out of that closed environment, and it's the one that dies, because it doesn't have survival capabilities. We need to expose ourselves. We need to exercise hard. We need to go into the salt water. Jack Cruz, you know, go to someplace in Mexico and just sit in the ocean water for days on end and get the microbiome from the spray into your system. Get the sunlight. Put stresses on your body. All those things. It's never one thing. The more diverse you can be about experiencing nature. And so just growing a simple vegetable garden with good nutrients in it, but the process of working the soil and all that stuff is really, really good for you. And don't wash that dirt off too much. I know it's hard to take, but if you were here, I ate the carrots from Renovatus. You know, they don't wash it. You know.
Yeah, that's right.
I'm still alive. I did an 80-mile group ride race last Saturday, and I just have to tell you the story. But I had this friend of mine. He's so good. He's never raced, but he's so strong. And we get into this. We pass 8 other people, and they join us. And then there's 3. And my friend Shannon, the doctor, he drops off the back, and he says, "That's too good for me." I said, "Shannon, you have no idea. You're so much better. Come with me." I ushered him to the front. The next thing you know, we kicked him off the back. So I'm here to tell you that the 62-year-old guy I know finished the 80-mile course faster than anybody. You know who that 62-year-old is, Alan?
You.
Correct.
Good job.
80 miles and a nasty Category 1 Tour de France climb. So it's like I mean, I put too much stress on my heart, but I was doing it all wrong before. You know, I was doing the carbs and all that, and then coming home and doing work. Now I come home and I have my Greek salad. I have my smoked salmon. My smoothie now, my smoothies aren't very tasty anymore. But I'm putting my kale in, I'm putting my avocado, I'm putting my blueberries in, but I'm putting lots of MCT oil. I'm putting butter in there. I'm putting hemp seeds. I'm putting hemp oil. If you can control the inflammation, you know, you still created the insult and you're going to be more resilient from it. So just keep those healthy fats up, folks. That's the most important thing to the brain. You know,
the caveat to that, though, is if you're ApoE4 poor, then you can't really do high fats like that, because it will drive the bad cholesterol numbers up. And not to say that, again, cholesterol is not the ultimate enemy, but however, once you get into the oxidized LDL range, and I've had a number of patients that had to back off of the MCT oils and the coconut oils and all of that, because it was really, really driving those numbers up. And there is, a realm when cholesterol can be bad,
So Dr. Carter can do the oxidized LDL test and the ApoE4 test. I don't do that, but I use the AIP as a surrogate for the oxidized LDL or the small particle LDL. It's not a perfect surrogate, but I want everybody's AIP, which is on the chronic disease temperature. We'll be talking about labs at some time, below the 0.15 threshold or 0.12. And if you're there, I'm comfortable that you probably can handle it, but if you're not testing, you're guessing. So. Any other questions? That's why I have Dr. Carter, because I'm sort of wide angle, and he's both wide angle and telephoto as well.
I would have never guessed you were 62.
Yeah, well,
maybe 52.
The guys I had a really great day. I won't tell you how many drugs I was on. No, but I take my decongestant and things like that actually increase your heart rate. But I used to race professionally, and then last year, after a long hiatus, I took it up. But it took me a year, just like chronic disease. It took me a year of really hard work. I mean, like painful work to develop the base I need. And like I said, in cycling, the way you succeed in cycling, because you're just there on the road so long, and it can be very monotonous. You have to enjoy pain. You have to focus on the pain, not focus away from it. And that's the key thing. So my mentor in cycling taught me that when you're in pain, everybody else is in really bad pain too. That's when you go harder. That's my technique.
I'm going to tell that to my son, because he just started the cycling. Well, he's been doing it, but not like you.
Amy, I'll talk to him about this sport anytime. Just have him give me a call, I'll tell him
I will. He doesn't call me, so I haven't heard from him in a long time.
I'm a cycling advocate. If you were, he'd be all over you. Anyway, it's too much self-promotion. I'm sorry to do that, but the point is, you can't baby yourself at any age. That's when you start losing it. You have to, what you did at 25 in terms of your philosophy on exercise and movement is the exact same thing you should have at 65. I really, truly believe that. I mean, there's a Scottish guy, he's like 5 feet tall, he's in his 90s, and he's doing crew with, the national champions, and he's like wicked buff. And, he's not really like a health guru or advocate. He just says, I like going out there and working hard. And I think that's extraordinarily important. And because in the end, a lot of longevity studies are tied to insulin and insulin sensitivity. And when you do hard exercise, particularly endurance exercise, you kick into the keto domain of fat burning. And that helps you control, the insulin levels. And, it's all linear, or log linear, but, you're insulin dependent, and then the longer you go, the more you're using the other pathway. So I may not even be in ketosis, but when I'm out there, I have to go into ketosis, and then my insulin is 2. And I'm probably not going to live super long because my wife says someday you're just going to drop dead. But I think if you are a little bit more moderate than me, and your insulin is in control, you're going to have a long, healthy life. I think that's an extraordinarily important marker for it. So everybody should endeavor to have an insulin of 4 or below, preferably 3, somewhere in the 2s. For complete optimal health is where you want to be in insulin.
Excellent.
Dr. C?
I agree. Yeah.
Thank you.
Between 2.5 and 5 is, the optimal range for fasting insulin levels.
Yep.
But I mean, you really, you also want to look at your postprandial or after eating glucose numbers. So that's, you could do that easily at home. You could buy a little glucose monitor, $25, the finger stick. And, you really want to, after 2 hours of eating, you really want to have your glucose numbers back down to baseline. And for those of you who don't know it, ideal fasting number is between 70 and 85. It's not 100.
We will definitely do a session on, insulin resistance and measurement and all that good stuff. So you don't have to worry about getting too excited about it right now. But your insulin is the best current surrogate, independent of that testing. But all these things add up to your story. So we will definitely talk about that. All right, folks. Thank you so much for being part of this. And
Thank you.
next week, it'll be Dr. Carter talking about the details on eye.